The world of reimbursement of wound care, I used to describe as a bowl of spaghetti, right? How do you find the ends of the noodle to understand reimbursement is crazy? It's really more of a bowl of pudding because it's even hard to tell where the noodles differ.
Pex Medical, Arizona, billed Medicare $1.2 billion and paid nurses $1,000 per application. They were sentenced to 15 years in prison.
Medical device companies, some of them made lots of money, spent it wisely, some spent it poorly. Others have really built a well-divested business. They've acquired their own technologies.
As long as there's human beings, there's going to be fraud, waste, and abuse. All of these small percentage of people create incredibly negative noise for a lot of good people that are trying to do good things with it.
If a single regulation change destroys your business, then I would question how structured and scalable your business was to begin with.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only.
Hello, everyone. Welcome to another episode of the Life of Flow podcast. And this is an emergency broadcast as per Miguel. He told me we have to do this right now on a Monday. And I'm like, okay, let's do it. So we have Miguel, we have Scott Nelson here. And Miguel, tee us up. What are we talking to you?
Yeah. The reason why I wanted us to do this, and as you all know, or you don't, I don't know, but we normally batch record. So given our complex, busy lives, we carve out every 2 to 3 months, and we take one day off, and we record in batches. But the problem is, Scott couldn't do it on our December batch, and I really wanted to air this show ahead of January, trying to be the Life of Flow Nostradamus show, trying to stay ahead of things, trying to be as contemporary as possible, and use Scott's experience here to help us dissect through a topic that I'll be very honest, both Lucas and I are not super well versed, but we know that Scott is, with his vast experience in the wound care market. He'll help us dissect a little bit of what's going on with this massive change in policy, CMS, apparently going into effect the first of the year for cellular and tissue-based products. And I guess for context, it's been I want to say it's like a $14 billion market, and I'll let you correct me here shortly, but it's a huge hit, which is trying to normalize and pave the road to, I guess, costs. And this is going to radically impact a lot of things because it's like slashing margins overnight and a significant amount. I want to say probably about 80%. 90% depending on the product that you look at. But I think that's gonna rattle this a lot. And we wanted to look at this from maybe the industry standpoint, maybe the provider standpoint. What do we do now? And here we're personally affected. I'll say that at Hope, I wouldn't say that we depend on it, but it's part of what we do, right? I mean, we have vascular wound care, podiatry care. So we have, a plethora of revenue segments. So I don't necessarily think that for us it's going to be this massive change, but I know, as a matter of fact, that there are people that's the only thing they do, and I'm sure that that's going to be pretty shaken. So I guess setting the stage up with what's happened in wound care, maybe let's take a step back before we go into the nitty-gritty of it and understand a little bit about your path, Scott. This is the first time on the show, and we always like to understand a little bit about your journey, when you started getting involved in wound care, limb preservation, and what are you doing what are you up to now? And then we can try to start delving into this particular hot topic for today.
No, I appreciate it. I appreciate the time. It's always a pleasure to get to know people a little bit more. I think, the chance to meet Lucas, here virtually tonight. I think you and I are paths have crossed a couple of times, even in the Hope facility there in Houston. So it's nice to get a chance to kind of spend some time together. So I've been in med tech, med device, depending on the year, the decade, what we call it, for about a little over 20 years. I stumbled into it purely unintentionally, transitioning out of the military. I was out in San Diego. I was a guy that needed a job, and I found a little startup. They were a job that needed a guy. I was cheap, and just kind of stumbled into it. So, doing early days of image analysis acquisition in the oncology space. And so I was managing the software integration, writing a little bit of the software on the code, writing all the automated installation and the integration, and then learned very quickly. I love the med device aspects, but didn't like to be a guy sitting in front of a computer all day long. Fast forward to being remote, post COVID. So, but at the time, I really liked the human element more. So, that kind of transitioned me into, hey, why don't you start up, right? Why don't you go try sales? I love sales. That was fun, but I was always asking a lot of questions about why do we do this? Why do we do that? They're like, hey, guy, you're bothering me. Why don't you go do marketing? Kind of, really pivot around that. So I had a chance to kind of grow in a startup environment. I was there for about 7, 8 years. Did the startup, venture capital. We went IPO. We did everything except make money. So all the combinations thereof, and then transitioned into orthopedics. So I spent a while, and as I describe it, went to spine and kind of swam down south. So started in spine implants. Always, I tell people always the sales and marketing. So I'm very commercial. I can understand the clinical aspects, utility, and need, but a clinician am I not. So I've always been in the sales and marketing commercial roles. Neck down to lumbar. So kind of spent a number of years in spine out in the West Coast. And then ended up in really lower extremity. So kind of did a hip and knee stints in some contract manufacturing through a lot of mergers and acquisitions, and they got into lower extremity. So I've been in probably the lower extremity space for about 14 years. I've been pure play wound care for the past 8 going into 9. And kind of what started the jaunt of many of the conversations I've been having the last couple of years is as I was getting into the wound care space, coming to it from more of a heavy orthopedic, hey, we're the big orthopedic, ortho bros, and we're the big market and all this stuff. And really, I wanted to understand the wound care space. And it's very difficult. It's very fractured. It's very fragmented. And it's harder to really understand what's going on in the space. And so a little bit of the self teaching for me to learn the market turned into a lot of the conversations over the past probably 3 or 4 years. What I've done is, I started the below the knee newsletter, which was just kind of a combination of I'm a market access and finance driven geek. And so doing market assessments on a weekly basis of what's going on. I got enough, just industry people asking and outreach. So I started a newsletter. I started the wound care fund. So it's kind of it really that began as a thought experiment. I mean, we all buy research reports if we're getting into different markets, and you can kind of think, what is the market worth? And that was again me looking at wound, going, what is wound? Wound is everything, it is nothing. It's a very very fractured and fragmented market. So I kind of started picking the publicly traded companies that were mostly heavily influenced in wound, and then I started expanding out into really. So if you look at limb salvage as a broader descriptor, what's the value of the market? So I kind of created the fund. It's not an investable fund. Could be any investors listening, right? Call me and let's talk. But it really is a thought experiment of how do we truly size and value, not size, but value the market. So if I look at all of the publicly traded companies that are in limb salvage, now we're getting vascular access in. We've got Charcot, or so you got a little bit of orthopedics that are in there. You've got obviously the wound care space, and create a fund. So I treat it like if it was a true ETF. So it's market cap based, fractional share aspect. I set a hard cap limit of what the investable amount would be in, and I track it on a weekly basis. And so that kind of began really driving a lot of the conversations that I began having that really formed, I think, ultimately how we're having the conversations today, which was then just diving in and dissecting the market and picking out what new trends, where are we going. It kind of a very long answer to a pretty simple question, but that's kind of my journey through med device, med tech on the commercial side. That's really immersed me into the wound care space. So I've learned a lot about the market. I've learned that there's still a lot more to learn about it. But those viewpoints really were driving me of like, where do I see innovation? Where are we oversaturated? What trends are becoming more commoditized from a price perspective? And then, kind of mapping the innovation wheel, right? Like looking at the 300 plus companies that are in wound care and aligning them to where they fit in the continuum of the patient treatment. And then expanding that now into education and kind of what does that look like? So that's been kind of how I've been looking at the market, how I'm building it, and really started kind of getting into where I'm now doing a lot of just the information, or I was coming up with all the LCD schedule, the physician fee schedule, the OPPS rule, the WISER. Um, so that's the one hat, and then the other hat, I'm still mired in wound care. I was in the biologic space for a while, so I'm intimately familiar with CTPs and camps and kind of the impacts to the distributors, to the manufacturers, as well as to the users and the end user physicians. And then I'm also vice president of sales and marketing with Swift Medical. So kind of an emerging upstart on digital imaging and AI in the space.
So, one of the things that I would invite people to do is follow your LinkedIn account. You know this by personal remark. I reached out one day and I said, "Hey, let's get on a call," and it was just a word of appreciation for good, solid content. Which a lot of times, I'll tell you what I do is I just repost stuff, but you actually sit down and you actually generate some pretty good content. Your newsletter is really good. And I love also a lot of the graphics that you've been developing, this wheel that in a way aggregates all of these complexities of the market. And to my surprise, by the way, somebody pointed out to me that the Life of Flow podcast had made its little logo onto your multi-billion-dollar wheel of fortune. Eh, and I was like, "We're definitely not
We are,
worthy,"
Miguel. Of course
but
we
but
are.
we love.
You
I know.
guys are I like
Well,
I like this is I like your podcast. It's fun, right? You go from, you'll have some world-renowned vascular surgeon in addition to you two, really way over my head talking about stuff, to then you got someone talking about how to grow their social media brand, to you got, just the wide gamut, and it's a fun listen. So I enjoy it. But it pushes education.
we appreciate that. We appreciate you eh, tacking us down onto the education component, which is certainly part of our core, and hence the reason why we're here today. So let's with that in mind and your journey in mind, which I think is self-explanatory as to why you would be in a position to at least help us digest this. Um, what is happening? And go as far back as you think we need to go to explain why this is seen by a lot as cataclysmic in the wound care market.
Yeah, no, there's a lot going on and a lot to unpack. So within wound care, and just for everyone listening, so the conversation is going to be really revolving around CTPs, camps, skin subs. So one thing to bear in mind is multiple. Again, I'm not clinical, right? But as I speak to clinicians and really dive in, so the big dichotomy is skin subs are generally, from those that I've spoken to. So if you disagree as a clinician, I'm just paraphrasing. So, but skin subs are generally about 10% of the care of the patient, because there's so many other things. Not every patient gets a skin sub. Not every wound gets a skin sub. There's other aspects that are pharmacologically treated. If you're doing a debridement, if it's a VLU, if you're doing compression. So we're talking about so much noise that has occurred in a relatively small aspect of the overall patient continuum. And the reason that it wasn't so small anymore is it's all dollars. So, skin subs, if we go back, probably pre-COVID, so 2019, 2020 era, podiatry did not have telehealth codes. So there was no even conversation about how do I do remote telepodiatry? Well, you don't talk about it. COVID happens, and we've now got, wound care centers that are closing. We have limited access to no access. We don't know how to care for the patients that need care, so it does not progress into an amputation. And what do we do? And so humans are creative. So they begin creatively saying, okay, well, I can do stuff as an office. Right now, we get all Medicare, place of service, POS 11, POS 22, POS 14. So we got people going, okay, I can use my van as an office and I can see the patient. So at least I can still pay my bills. I can bill Medicare. I can do things, keep the patient. And so that began, that creative solutioning. We're kind of coming out of COVID. People are seeing that, there's a new modality of practicing. Telemedicine was authorized during the COVID period for podiatry. So there's a reimbursable aspect to it. We can get creative. We can reach the patients. So the beginning of this I don't know, I still see it as very altruistic. It wasn't anyone really trying anything. And I think as they began saying, okay, look, I've got this practice, I'm seeing patients that can treat wounds. Hmm, can I do a skin sub remotely or not remotely, but through an out of traditional care setting? And so, really what we ended up seeing was, yeah, you can. I don't think anyone ever said you couldn't. They just didn't try. So now I can begin treating patients and applying skin subs, but how do I build them? And so the world of reimbursement of wound care, I used to describe as a bowl of spaghetti, right? How do you find the ends of the noodle to understand reimbursement is crazy? It's really more of a bowl of pudding because it's even hard to tell where the noodles differ. It is the fact that I can be the same physician in the same patient. And if I'm in a hospital, completely different economic conversation, purchase, price, reimbursement, billing than if I'm in a wound care center, than if I'm in a physician's office, than if I'm in an ASC. Same patient, same physician, same products. So depending on where you are, everything is a completely different value in way that you transact them. And what we began seeing in the mobile world was because the skin subs are reimbursed, this will change in a couple of weeks, right? They were reimbursed as a cost plus. So if my or an invoice plus, depending on MAC, right? So I've got 8 MACs in the country because none of this was ever under national code determination or NCD. So
Can you break
each
those acronyms down a little bit?
yeah, I'll try. We're we're
Yeah.
we're gonna reach in the end of my knowledge. Yeah. So a local, so a MAC is a contracted administrator of Medicare, and they've got a geography of the country for which they're responsible. And they can, in effect, set their payment policy within reason. Medicare may set the reimbursement rate, but they can always reimburse less, or they can kind of, if they publish guidelines or standards, or they'll kind of make determinations within their area.
And
So
what's
within skin,
cost plus? What does that mean?
so cost plus was if you're reimbursing a skin sub in a place of service 11, so physician's office, they're going to invoice or reimburse the skin sub at the invoice or the cost plus a delta, usually with either 3 or 6%, depending on the MAC that you were in. And so, okay, if I paid $100, then I get $106 or $103. In there, maybe there's a geographical markup if I'm in New York City versus St. Louis, Missouri, a nominal rate. And so that was intended to cover the cost of the skin sub and the application kind of bundled in. And what challenges the industry faced was that if I get a higher invoice, I get reimbursed more. So it's not, not a fee for service. It's not capitated pricing. Like a wound care center operates like a mini hospital, right? I've got a bundled DRG effective payment, and I have to manage those dollars. Within the physician's office for skin sub, and I'm sure there's other things like that, but just the focus for skin sub is, so if my invoice was $100, I get 103. Well, if I charge you 10,000, you get 10,000 plus 3%. The challenge we begin running into is then with rebates. We're used to in the hospital environment of like a GPO rebate for volume base. So that being kind of the incentive is that's what bridged the big gap is now I'm being invoiced for a higher price product and companies have to make money. Physicians, nobody's volunteering their time, but it created an opportunity for questionable behavior. So I'd say, one thing that's come out of this is the vast majority of skin sub applications. I think there's been 2 papers that were written. I saw one presentation on it. They're probably roughly 10% of providers using skin subs really kind of fall into the camp of it's getting clear cut abuse of way overpriced to way cut the difference. But really, what happened is we're just seeing these astronomical markups. I come from the skin sub production world, so I know what it costs to make these. And you're seeing ASPs, average sales price. So the other thing that happens in the physician's office is when you are, selling into the physician's office as a company, you can choose to make your ASP public, and that's what determines your published ASP rate, and that determines the reimbursement. So if I have ASP, I'll invoice at a high rate, and if my ASP is a little bit lower, then we'll bill off. So that creates some of this delta, provides margin.
So explain that again. So what I'm getting is that there's an incentive for physicians to buy higher cost skin substitute because the percentage is going to be a higher total amount. So
Well, and
like a pervasive.
it's physicians, it's distributors, it's manufacturers, right? So everyone is paid based on the price of the product, but not in a way where you're penalized for a high priced product. You're actually rewarded for high priced products. So the behavior, was not in line with where it should have been.
And
And so
talk about what you just mentioned about, I don't know, you just said something that I kind of missed. What was the crux of it?
So yeah, so if if you're making your ASP, so as a manufacturer, if you're selling your ASP, you're not providing it, but CMS is capturing this information because they look at the Q codes that are being claims and being payments, and so they look at what the average selling price of the products are, and then they will publish an ASP on a quarterly basis, and that really drives your reimbursement. So as I lower my if I'm discounting, it brings my ASP down. So if I can manage, some of the levers here where I've got a high price invoice and your reimbursement is driven off the invoice, but your reimbursement comes off ASP. So I'm creating this gap that allows for high margin. So for example, what
Because
we're
there's going to be
seeing,
a spread between the
yes,
data's lagging, is what you're
yes,
saying.
yes, it
Okay.
lags by 90 days. And so oftentimes you may see, companies kind of produce multiple products, right? Because they're catching, right? So one price is coming down, so I introduce a new product at a higher price, and eventually that price is going to come down. So it's a kind of a never-ending game. But what the impact of the market is, what may have at one point a few years ago an ASP of, we'll pick on antibiotics; those were kind of the predominant products, but it's not limited to that, right? It's any skin sub. But you're seeing where we were at one day, 500, 700, maybe $1,000 per square centimeter. If you got stack costs that come up, now we were amazed when we hit 2,500 square centimeter. Then we were amazed when we crossed 3,000 a square centimeter, and we've seen graphs that are over 4,000 square centimeter. And so that's what the culmination of all the noise has been. So if you read like the CMS charts or the CMS press release where they're talking about this, $10 billion, skin sub. A couple of years ago, the skin sub US domestic market was right around 2 billion, right? 1.8 billion. I don't really understand where the CMS $200 million number comes from. They go, they say we grew from 200 million to 14 billion.
What I have some data here is saying that CMS, some trends in spending. So Q3 of 2022, the whole market was 389 million. Q3 of 2024, it grew to 2.88 billion.
Okay.
Total 2024, 10 billion. Projected 2025, 15 billion. So in
And those are
3
quarterly numbers.
years, no, so the last two are
Okay.
total. So 1.6 to 15 billion.
Yes. And
That's it.
not
So
in a long time. That's a pretty short
not a
period
long
of
time.
time.
So you're saying 10% of, people putting these on are creating that delta?
Well,
That seems...
no, I think because when the price of everything comes up, that drives the overall market up. But I think like there's been, New York Times op-ed articles that have come out. We've seen, out west, there were a couple of states where there were some, judicial activism going on. We saw there were a number of issues. I think there have been providers as well as distributors that have been sentenced, that have been fined. So those are the ones we've seen a relatively small number of people that have been driving the massive gap. Meaning I'm paying 5,000 square centimeter, but I'm being reimbursed on the back end 3,000 a square. So that's because this opened up the opportunity for some incredible financial gain in very small pockets. That was
I'll give you some
yeah.
I'll give you guys some examples of financial fraud. Apex Medical, Arizona, friends of the pod. Joking.
Sponsors.
They're
Joking.
sponsors.
Were the sponsors?
Joking.
Proud sponsor of the Life of Flow.
Proud. They could. They billed Medicare $1.2 billion and paid each nurses $1,000 per application, and they were sentenced to 15 years in prison.
Yeah, and that was 900 million of that was skin sub, if not more. And again, that's just that the ability to generate that much profit then drives decisions. They were putting skin subs on patients that were end of life, that had no business being treated for wounds, right? Because it was a billing game, and there's been more than just that instance.
That's what I was going to mention. Listen, as long as there's human beings, there's going to be fraud, waste, and abuse. And what's sad here is that all of these small percentage of people create, incredibly negative noise for a lot of good people that are trying to do good things with it. And I'm just trying to bring some balance into it. And I'm not saying that what happened is unfair or, I think it was a necessity. You can't work at cost plus because it's essentially giving everybody free reign to just, set the price point. And then, the federal funds had to just pay them. I like my analogy of a lemonade stand, right? I mean, before, let's say that you would buy a lemonade at $10 and then CMS would let you charge 12 because it was the price of the lemonade plus your price on that. And so you get to keep $2. Well, that's not entirely true because you can also negotiate that $10 down. And so even though you bill Medicare at $10, you may ultimately be able to get it down to 6. And that creates a margin of not $2, but then $6.
Is that fraud or is that legal?
It is legal. It is legal
It's
through
legal.
there's legal constructions by which you can do bulk purchases, by which you can do, and I do, this is a typical practice for me. I mean, if I buy one IVUS catheter, I pay X amount. If I buy 30 IVUS catheters, I pay a discount and I can buy
Yeah,
it at
but
a discount.
the rate of payment.
That's the thing. The fact of the matter is that when you present the billing, there's no accountability to whatever you can do post-doc, if I may, okay? And therein is a lot of language that could obviously lead to fraudulent activities. And then when you add that to just unscrupulous medical clinical behavior, like putting this on terminal patients, putting this on, bedridden patients with cancer and a sacral decubitus ulcer, and you're putting $50,000 worth of product in their butt full of feces and infection, that's fraud. You're not helping anybody. You're certainly not helping the patient. Maybe you're even putting them at risk by adding biologics into an infected field. And that's the bullshit that was happening. But now we're at the point where now CMS is saying, you know what, guys, I'm going to keep paying lemonade, but I've decided that the lemonade costs $3. And so go figure it the fuck out. Because now what happens? And that's part of, I guess, what I would, let's start working into that direction because this is done. This is a done deal. It's not like there's, I believe, right? Am I correct, Scott, that this is a pretty,
Yeah, I mean,
this is
it,
happening? There's no pedaling back?
it's not. Well, I mean, till the ink's dry. So, this is not a proposal. This is not a draft. This is not an anticipated. This is a stated declaration of change that will happen. Now, I know there are. So let's run back through what those items are. So there's really 4 activities that are in play, and this still goes back about over 2 years now. So you've got the LCD, so the not national coverage, but the local coverage determination. So I've got a draft LCD guidance that came out, and that said that we're going to set a arbitrary bar that none of these products have clinical data, and so you've got to have clinical data for us to continue covering and reimbursing you. And so they came out, and I think the first thing that came out, there was like 12 companies. Everyone yelled. They pulled it back. They reintroduced it. They came out with a public comment period of about 9 months. Then they came up with the formalized thing about a year ago, or almost a year ago, and it's set to take effect in January. What the LCD changes are is that covered products, and I think they listed 17 that may grow, and they're saying that we're only going to reimburse. They're not saying what they would reimburse. They're just saying if you are a covered product, you will continue to operate and you will be reimbursed. And oh, by the way, we're only saying at last I checked, 17 products, maybe 20 products, and about 7 or 8 companies that have these products. Now, is that going to, there's all we've been talking about lately is the physician fee schedule, the OPPS rule. And like, oh, by the way, what happened to LCD? As far as I know, they're still coming out. There are schools of thought. Will they or will they not? The challenge with the LCD, the good thing is it established a need for clinical data. You've got to have at least a barrier to entry. So if I want to go out and launch a new product, I should have barrier to market entry before I can do that. If it's just I need to source it, file online to get a Q code and I can start selling it and you don't need to have any data whether it works or not, that's a challenge. So I do see the value that establishes. I need to have a level of concordant data that shows at least my products is good. So if that hits January 1, a lot of products will no longer be covered, but many of these companies have been investing substantially in trials since the LCD came out. They've been submitting data. They've been getting publications. So I would expect to see that may take effect, but the list gets much, much larger because you've now got companies that have substantial data. The two big things that the challenge with the LCD is it didn't change anything about reimbursement. It didn't address it at all. It just said, hey, if you're 17 companies, you guys can go check your prices out. We're just saying you got to have data. Now, the two things that have been driving the big numbers, like we mentioned about $4,000 a square centimeter a minute ago, is kind of the extreme, right? The highest. The average is much, much lower, but it's still well over 1,000. What the physician fee schedule came out, and they said that we're going to reimburse skin substitutes at $127 per square centimeter. That's your $3 eliminated allergy meal. Right? So we're going to reimburse you. You can use them. You can do what you want. You get $127 per square centimeter. There's another difference is that Invoice Plus, remember, was just physicians' offices. We had a different reimbursement in wound care center, HOPD wound care center, and then we had a different one if you're in any other side of care. So the other thing it is, they also normalize this is if you are outpatient, this is what we're going to reimburse skin subs. So we're going to kind of remove some of the confusion, and we're going to do three things. Then we're going to normalize reimbursement of skin substitutes for all outpatient settings. That introduces ASCs, which ASCs traditionally have not done skin subs because there was no reimbursement in ASCs. So not sure what that might look like going forward. But that's the one thing is we're going to normalize payment in the outpatient setting. We're going to drastically reduce it. We're going to do $127, and they cited the studies that they looked at with multiple companies that there is logic behind that. It's definitely low. And I think what was the third thing I was going to say? The third thing they were going to do. So normalize that, we'll cut that. Oh, and then we're going to provide, so it's not just a bundle payment for everything. So that 127 is for the cost of the graft, and there is an application fee for the physician separately. So, it's, I think $600 or $700. I could be mistaken, but nominal fee. So you're going to be paid to apply it separately for your time. This is just for the cost of the purchase, the graft that you'll be purchasing.
So theoretically, people could still take advantage of the spread, the delta between the ASP and the actual.
ASP goes away.
The ASP goes away.
Yeah. So now if you submit reimbursement for a skin substitute, you're going to get $127 per square centimeter and some change.
Oh, that.
So
it doesn't matter what product.
If you can still purchase it for $500 a square centimeter and lose money. So it's really driving the cost down.
Oh, so all products
Yeah.
is going to
Product.
the maximum they'll pay is and you knowing the
Not maximum. That's what they will pay.
exactly.
There's not going to be a range.
range.
That will be the fixed payment.
And you knowing the industry, is that profitable for most makers of these products?
Yeah, I'm pissed a lot of people off, but it depends. So I can
Let's say I don't know.
Probably yes.
I'm not sure.
There's a path toward a measurable margin, but again, now we've got a manufacturer, and it depends, right? Are they, this is skin sub. Skin sub can be a 361, human drive. It can be a 510K xenograft. So that can be animal drive. That can be a synthetic, like a lab produced synthetic. So the cost structure is going to vary greatly. I'm going to be most familiar with the 351, 361 realm. I've got anecdotal knowledge around some of the synthetics and the xenografts. Generally speaking, the production is going to be there. So you should be able to produce these below that level of cost. But now as a producer, our industry has been built by kind of stacked dollars. Because as a producer, I'm not selling to the physician, right? I'm going through a distribution channel. So now I've got a national distribution network with sub-distributors. Am I selling into a hospital? Am I selling into a hospital system? So I've got about 3 or 4 hands before I get to the end user. And that's going to be that disruptive change. Whereas in the mobile, so the big hit is this is going to be the mobile impact. But before we get into that, so physician fee schedule, BFS hit. Everyone's like, okay, what's going to happen with the outpatient physician, the OPPS rule? So that came out, I think November 1st, or no, November 26th, right before Thanksgiving. And they're simply mirroring. So they said, okay, we're just going to match the 127. So there's no discussion, no arbitrary. If you are applying skin subs in the outpatient setting, they did add some additional languages. So now there's a pathway for non-sheet forms. So because there's always been a question about how do I do some of the like the powder and different micronized formulations. So that has a pathway to be reimbursed now. And then some noise that they added in around like remote patient monitoring and a little bit of forward-looking discussions around software as a service. But the big thing is PFS, physician's fee schedule, OPPS, outpatient payment rule. They align, same dollars, same numbers. They change it by 14 cents the next day. They put a pressure. I think they exactly match. So that's gonna now, come January 1st, if you're applying skin subs in any outpatient setting, you have to negotiate your price, right? You've got to, because your margins are gone. If you were getting 5,000 and buying it for 1,000, that's gone. You're going to get 127 per square. Now, I think what's going to happen is this is definitely going to impact the mobile. Now the mobiles, again, they didn't used to do skin subs. They were doing more, you would argue sometimes maybe more wound maintenance than wound treatment because of what they could do, what they could afford to do. So I know many, mobile providers were using this as a bridge to cover what they may have been losing in others. So, I think a lot of companies are going to be reassessing. It's disruptive. It's going to be painful. Um, Depending on how your business is set up. In the same day, I spoke to a mobile provider who was planning on shutting their doors January 1st, that I spoke to a mobile provider who was looking at how many companies they can go acquire and do a land grab because the opportunity is there, because their one was much more dependent upon skin sub revenue, one was much less dependent upon skin sub revenue. So it depends on how you structured your business, and these are providers. On the distributors, it's going to be a different story. There's several large skin sub distributors who are almost medical device companies now. I think, some of them, made lots of money and spent it wisely. Some spent it poorly. Some had a good time. Others have really built a well-divested business. They've acquired their own technologies. So there's some distribution companies that are really operating as, medical device companies now, and they were fortuitous. They had an opportunity to go, create massive revenue, but they reinvested it and grew. Those businesses are going to be fine. The ones who are only selling high dollar antibiotics and really kind of looking at, they're, enjoy it, but that's not a sustainable business either. I equate this that, we live and we all decide to have careers in a regulated environment. You've got to be anticipating regulation changes, and you've got to be able to withstand them. If a single regulation change destroys your business, then I would question how structured and scalable your business was to begin with.
I mean, if you see that in 3 years it 10x the expenses on Medicare, you kind of have to guess that, hey, something's going to come down the pipe because
It's not scalable. And it's not real market growth. We didn't 10x patients. It's the same number of patients, the same patient population. It's the same number of procedures. Humans didn't all of a sudden get 10x more efficient and I could do all this. No, this was pure price driven, which is not a reasonable expectation how to measure the market. I think if we look at just prior to this, I think 1.8 billion was kind of what I was looking at. I look at annualized numbers. I think you mentioned a quarterly 300 or so million comes out at 1.2. So we're in that ballpark of that, roughly the U.S. domestic skin sub market prior to all the noise was in the 1.5-ish billion, give or take a couple hundred million. Big numbers, I know, big range, right? Now we're at 10 billion, 14 billion. My guess is we're going to see a correction. If I were to plot it on our chart, where would the growth 4 years ago have been? That's probably where we're going to land, right? Because we're seeing everything else is normalized. So the patient flow, if I proceduralize this, it's when I typically do a market assessment, right? I'm looking at what's the procedural volume, who's the patients I'm going after, what's that mix? The patients are what drive the growth because that's, the end user, kind of the customer without being the customer. So if I take the market gains away that were overly done in dollars, mostly done in mobile. Mobile really wasn't a monitored market segment prior to this. So, I think what we're going to see is where do the patients go? I think, office-based and wound care centers will probably see an influx of larger wounds because they didn't get paid to treat them before. If I'm a wound care center and I've got fixed dollars, 1,300 and change, do I want to work on a 10 square centimeter wound or a 100 square centimeter wound? Well, I'm going to pick the 10, right? The 100, I'm going to lose money on. So I'll do some, but I got to manage what I can do. Well, now if I'm paid based on a fixed cost, 127, but it's based on the size of the graft, that should equate to the size of the wound. Then the larger wound patients probably going to come back into wound care centers and offices because economically makes more sense, and they got the infrastructure.
Yeah, I think what we're gonna see is we're probably gonna see a shift in utilization. I'll give you an idea, and of course these are just numbers, but there are like high end substitutes like amnio, choreo. Those were like the more expensive one. And there's like mid range ones. These expensive ones could be like 1,000 per square centimeter, okay, in reimbursement. Then there's like this middle range, which could be like, I want to say 150 to 250. And then there's actually stuff that's like acellular matrices and stuff like that, that probably could easily be in the 50 to 100s. If you then normalize all that to 127, then you know that any decent group that has mathematics is going to say the only way that I can be sustainable is not by applying the 1,000 plus, products, is I'm going to have to shift away from that to continue having margin. At the end of the day, no margin, no mission, right? For hope, we need to be conscious, right? I can't just use the 127 and splurge $1,000 per centimeter because I'm going to be losing money on every application. And so that's not sustainable. And so what we're probably going to do is we're going to see the LCDs, right? We're going to see what has the best data. And as of today, out of 100 products that may be in the market, 120, there's like 15, I want to say, that have some okay data. And so then can you find okay data within the lower cost products that still have margin to feel like you're doing the right clinical thing for your patients, right? That you feel backed up by some data, that you're applying something, and B, that you're being a good business owner because you just can't do it sustainable. And I think that's going to be the reflex. At least here's my playbook. And I mean, everybody that knows me knows that I don't necessarily have a PhD in math, but here's our playbook. I'm going to say, okay, guys, we're going to look at who has, where do we still have margin on products that are still going to be good for us, okay, and for our patients. And then I think a little bit slower is the market's going to have to readjust. Because if these companies want us to still continue offering our patients amnio and chorea products, which are some of these higher bioengineered products that probably carry a lot better data, then they're just going to have to be made at a price point that we can still get them. And so what has happened, you said it very, very well, Scott, is that because of how hyperinflated the market was, that bubble, it had generated all of these subs that all took a piece of the pie before I got my product. I think all of that's going to have to be cleaned house. So most of these middlemen are probably going to go away. And there's going to be a lot of litigation and contracts, and who knows what's going to happen. It's not going to be overnight. But that's the first thing that needs to go is as a company, you can't sell a product and expect it to go through 10 people before it reaches the doctor. The big companies are going to have to come to Hope, and they're going to want to be part of Hope. And we're going to have sustainable relationships because FYI, maybe we could be helping you with the data you need. So it's not really a commercial relationship. It could be a relationship that's far and beyond. Like we could do research on certain products. We could be part of RCTs. So we still have access to the product. We may not necessarily pay full price, but I think that's what you're potentially going to see from groups like us. And we're also, there are a few other things. I mean, there's a lot of other products in the wound care market that have decent margins. I mean, they're not, you can't have a private jet, but there are things like different debridement options like Ultra Mist. Um, there's PRP, platelet-rich plasma, that Medicare reimburses at certain, and so I think that you're gonna have to. We have a very diversified portfolio, and so even though, yeah, skin subs, was a nice part of the business, for us, it's not really like the sky's on fire because we have all these other things that we do. But I think that's what we're gonna see. We're gonna see lower products being used, lower cost products being used initially, so that there's a maintenance or a protection of the margin, and then heterogeneity in the offerings. Like I said, Ultramist, PRP, some other these things are gonna start. It's the only way you can survive, uh, unless you don't think you have any capacity, and then you're just gonna fold. And we've had two companies already essentially come to our offices and say, "We're folding, we're closing down. We've got 20 patients that we want to send your way." And we're here. We're like, "Sure, we'll take them. Whatever you need us to do," because they want to do the right thing by their patients, but they had mobile and they just can't take care of those patients anymore. So they're coming our way.
Miguel, let's talk a little bit about the data because my perception is that most physicians that I've talked to, and me included, think that the data and all these products is suboptimal at best. I looked up some. There's some. None of the like when these reps come to the office, there's limb salvage or prevention amputations seldomly in the outcomes. At least that I remember. I may be wrong. I looked up. There's some meta-analysis that state that there's limb preservation with the use of it, but you know I looked up and to this so. We've been using for DVAs Matroderm with a little concoction that Demetrius, one of my partners, made, and we've been having good results. And I looked it up. Matroderm is $5 per square centimeter. Integra is more than 3 times that. So like, and I don't even know how to gauge it. To be honest, I have no clue on which of these 17 substitutes has the strongest data. Do you have a grasp of it? I just don't deal with it. I don't know if you do more.
Yeah, well, I mean, as you know, I rely heavily on my wound care and podiatry counterpart to manage that. But off the top of my head, I know there's pretty solid data on diabetic foot ulcers with like Apligraft. I know Dermagraft has some data graphics.
And are they looking at limb salvage? Are they looking at limb salvage, or are they looking at wound healing?
No, these are primarily
Yeah.
DFUs. So standard of care, yeah, these are all related to diabetic foot ulcers. And so you have to have a specific type of diabetic foot ulcer. You have to exhaust standard of care for X amount of days. You have to have a very clear understanding. You have to have measurements of all these. Because here's the deal: when we started this, it wasn't if, it's when you're getting audited. And we actually even created. You've seen this, Lucas. I've shown you this, but FlightPath is a software that we built at Hope to actually track all these things. So, for example, you need to make sure your TBIs and ABIs are in the right spot. You need to make sure that you know what bacteria are lingering in this ulcer. You need to optimize offloading, and you need to do standard of care. And all of these things need to happen even before you ever consider doing one of these. Now, once you get to that point, you still have to do a pre-authorization. It's not like you can, just you get a skin sub and you get a skin. So we have to absolutely be approved for that procedure, and then we move into it. Now, is there anything on limb salvage? Not to my knowledge. I think most of this stuff is either on. There's a lot of chronic venous ulcer stuff. There's 2 or 3 RCTs on venous, and that is a big approval pathway. And then the other one is that DFU.
Yeah, there's a couple. So if you think about the covered, sorry, Lucas, but on the limb salvage, so like the covered products, right? I mean, I think LifeNet Health has a couple. You got Mimetics, Organogenesis, Kerecis. Um, the studies are all going to be DFU VLU. When I was at LifeNet, we did a deep wound study, and it was not a limb salvage study, but we did a deep wound study because really also all the studies are they do a good job of doing what they are intended to do, which is show success, and generally in smaller wounds because I want to show what my accelerated wound area reduction size within that 16 week range is. We want to do a larger wound, and so we did a study when I was at LifeNet. I think our mean wound size was 25 square. We went up to 113 square centimeters. So large wounds that were all Wagner's 3 and 4. So it was not a limb salvage study, but we wanted to see how's the product perform on these large wounds that typically are going to go toward amputation. So we did see a reduction in amputation rate as a meta. It wasn't an arm of the study, but if I compare this cohort to the others, but the reason there's not a lot of limb salvage studies, because we did that because, LifeNet is, they're a tissue bank, not for profit. So it really a geared towards studies. We would really want to see how the product performed in these areas. Generally speaking, if I'm industry and I'm going to go pay for these large scale 100 RCT studies and millions of dollars, I'm doing it because I need private pay coverage. That's how I'm going to get beyond Medicare. That's how I'm getting Advantage. That's how I'm getting Aetnas and Blues and Kaisers. And what do they want? They want peer review level 1 studies that are showing wound area reduction so I can get their coverage. So why would I do a limb salvage study? What's it going to get me? That's one of the challenges.
Plus, it's so messy, right? With limb salvage, you add infection and ischemia into the crock pot, and then everything simmers on slow for hours. It's hard.
I think the ischemia component could be important because there could be a.
Well, you couldn't be ischemic to be part of any of these studies. That's the
I
thing.
know,
Yeah.
but like if you do somebody with tibials, what I'm saying, like you revascularize something with somebody with tibial vessels, the chances of that going down at some point during the course of wound healing are high, so they're gonna be ischemic or partially ischemic to a degree, right? Am I wrong?
Yeah, well, you and I have talked about this. I mean, we're in a chat where we've been talking to a bunch of international guys about no option and what standard of care is of the management of what we call wound hospice. And this could be an interesting thing, which is in the actual ischemic patient with no options for further revascularization, where you're considering a deep venous arteriolation or something along the lines of, could you have an arm that has biologics and just see what that result is? Now, classically, none of these products help if you have an ischemic limb.
Well, I
And I guess it's the
when
same.
I do guillotine, when I do the guillotine, when I have to do guillotine TMAs and DVAs, I usually slap on some Matroderm
An
with
Integra.
I do Matroderm with some concoction of collagen and antibiotics and shit like that I have no data for, but seems to be working. And it's ischemic, until a month and a half. So
Yeah, so people like you got us where we are, Lucas.
no, dude,
Making
I
shit
do
with no
like
data.
one DV. I put it on like one patient, every 2
so he
weeks
yells-
or
Oh, I'm
something.
joking.
Yeah,
He yells at us sales guys for not having enough data when we walk in to talk to him, but he's doing this with no data.
yeah, man.
Yeah.
I'm the physician scientist on the front lines.
So we don't have a ton of time here, but I love your perspective from an industry standpoint. I gave you my very uneducated stance, which is the middleman goes away, and they're going to have to figure out a more creative way to bring the price down, or they're going to have to go all out on a war at the Hill with all of their torque and try to get this to be revoked somehow, to be able to have to have higher paying amounts. What's your thought, the reaction from industry is going to be?
So the latter's already happening. I'm aware of at least 3 efforts, all kill related of, whether they're pushing for national coverage determination. No one's pushing for it to stay as is. But it's, the argument is 127. Is it too low? What's sustainable? Everyone's going to have their formula that drives what they want. But I know that there are congressional efforts being, lobbying efforts right now that are going on with 2 different organizations. I know there is a push for a congressional bill. I don't know how that works. I'm not a congressional lawyer, so I don't know how a congressional bill would somehow cause a national coverage determination. And I'm paraphrasing what I'm hearing, but there are multiple efforts going on. Whether that happens or not, so CMS did come out and say, look, these rules are hitting January 1 in 2026. Now, January 1, 2027, we'll reassess. Where you were talking about earlier, Miguel, they are going to be looking at stratifying reimbursement based on, PMA versus 510K versus BLA. So, your data required for approval will then be tied to the reimbursement level. So I think what we're seeing is what the bottom's going to be. Now, are there opportunities for it to come up? So I think there's numerous, Super Bowl chart picks right now of where do we think it's going to kind of fall. I would say probably January is going to be January. Now, is something going to happen in 6 months where you see a temporary lift, or does 127 become 400? That there's room for that. But I think people need to assess. You also, do we need 232 amniotic grafts? That are probably produced by 75 companies, because there's a lot of white label. There was so much noise, right? There was so much opportunity. People got creative. There are multiple white label grafts. So I think we're definitely going to see a consolidation of the space. Mobile providers are not going away, but they're going to have to be smarter about what they are doing, what services they provide. The economics come back to reality. If you're going to run a business, you got to run a business. You got to be smart. You got to look at what your costs are relative to the revenue stream and manage your margins. Margin drives, mission, margin drives the mission. I think that was our saying at Life, that the not for profit. And it's, we all choose to be in healthcare for a variety of reasons, some altruistic, some economic. But at the end of the day, no one is truly volunteering their time. And you've got staff, you've got overhead. I'm at an organization. We've got the same thing, right? We've got costs that we have to maintain. So I've got to be able to provide the right value for my product. And I think we're seeing, that it was overdone. So this is whack-a-mole. Every couple of years, Medicare is going to see an overuse of a different product or technology. The reimbursement gets out of hand and they cut it. I mean, I've seen segments and sub industries lose reimbursement overnight. So, this is no different now for the group of people involved. It's just us, right? It hits home. So I'm optimistic that it's going to stabilize. I think one of the soapboxes I've been on recently is really the for such a small percentage of the overall patient continuum, we spend too much damn time talking about skin subs. It has gotten too much of the limelight. It really hurts the limb salvage wound care industry in the billions of dollars that we've chased investors away. We've chased innovation away. We've been caught up in the soap opera that we allowed our industry to become. And I'm looking forward to some stability.
Yeah. I mean, I'll even tell you backlash of groups that have been at the table talking to us about possible infusions, connections, etc. And that those phone calls have stopped when this happened. And so I've tried to reach out and say, guys, we're not being directly affected by this, yet somehow this has tainted the investors, right? Be it private equity, be it private groups, whatever that is that, yeah, not that it was going anywhere really interesting, but that's one thing that was like, well, there's too much heat on this whole wound care stuff. We may, I don't know, I haven't heard that word by word, but I'm guessing that that's what pushed these particular people potentially away from the table that they were very interested initially. But I think in the defense of the companies and my hopefulness that there is a little bit of a correction is because at the end of the day, you it's not just what the cost of the product is, it's the management of the business, it's the dollars that could go into R&D, it's the dollars that could continue pushing the specialty forward. And there has to be some gain. There has to be investments. There is a financial conundrum, but there is a healthy financial conundrum that needs to happen for things to continue progressing. And I do agree. I think this whole skin sub thing has just taken too much centerfold and removed us from or made us lose a little perspective on the fact that there's still a lot of things that we could be doing in the wound care space to progress, to advance, to disrupt, to modernize, et cetera, et cetera.
Yeah, I mean, it'll come back, right? The pendulum swung far. Is it going to stay there? No, it'll go somewhere north of that. Where I don't know, $511.31. That's my guess. So we'll see where it ends up. But whether it's in January or the first half of the year, but I expect to see some degree of uplift. But again, skin subs need to just remain that. There's so much, and yes, I would say that investor pullback over the last 4 years of all this noise, my estimate is in the $2 to $3 billion range of what we've seen. If you look at normally what venture capital, private equity, kind of family office investment across the industry looks like on an annualized basis, significant decline at the time when all this noise has been going on. So if you're in wound care, you've been hurt by this. But I think, out of it comes, right, good opportunity. I think let's get to a stable industry. Wound care and limb salvage is the same size as global orthopedics. We just don't get talked about the same way, and we don't behave the same way. We're as impactful of this industry as the global orthopedic segment, but we have a bigger impact. The cost to society is higher. The cost, to treat is higher. These are non-elective procedures, so we're a bigger industry than we let ourselves get on. And I think there's good to come from this. Let's get stable. Lots of innovation to come. You mentioned audits. Audits aren't going anywhere. That's a 6-year look back. So there's lots of those to come still.
One final question: does the patient get affected by this, and how? Positive, negative, long term, short term?
Short term, it's going to be, I think negative, right? If their source of care dries up, what do? This is a patient population that can just hop into their second car, go reschedule an appointment. So if they don't have a source of care, what do? I mean, oftentimes we get house, right? They're in the position because they chose not to seek care to begin with. So that's what they're going to relate to is, well, I'll just stay home. No one can come to me. Can I get to the office? Where do I go to the office? Who do I find if I can't? So there's absolutely going to be, I think, a negative connotation to the patients. So, we're going to see, increase in amputations. We're going to see increased mortality as they lose their sources of care. Their sources of care. How do they find them? How do they know about them? And how do they get to them? I mean, long term will stabilize. Again, mobile isn't completely going away. It's going to shift. It has to be more stratified about how do you provide that. So, I think there's a lot of innovation. I think, I'm in the digital AI space. I think it opens up a lot of opportunity for data, for getting access to data. So kind of one of the things that we look at with Swift is now I've got, also, there's fluorescence. So as you're layering on solutions, there, Miguel, right? So how do I ensure that I don't have, a biofilm built up without needing to do something? Does it aid? Does it, so these are complementary technologies, but the data. So one of the things that, that we like to do with Swift is, my words, not the official company line, but it's how do I take a value-based care approach and bring it to as small as an individual provider. So if I can digitize the treatment of the wound, if I can have not only digitize it, but I'm not transactional. So I've got a portal in the back end. So you can really see the stratification of your patient continue. If you've got 10 providers covering 2 states, 30 patients, a week, that's a lot of data points. So I can dashboard, I can really see where are my true stalled wounds, which ones are healing on the prediction that I would expect. So I can now better manage my costs relative to the patient need. So I can be smarter as a practice by incorporating digital and AI technologies. If I know where all my stalled wounds are, do I see trends? Or maybe that's where I shift some of my higher dollar acuity care to those patients and reserve the lower care for those that are on a more normal healing trajectory. So as a result, using these types of tools, right? So it's a tool that doesn't touch the patient, but through deployment, we see accelerated wound healing because I'm giving you access to the data to be a smarter business person and keep that clinical reach. So I think those are the types of things that will help.
If you can put in a variable of which substitute you're using, you can probably determine which one works best for you, at least for your particular practice.
Absolutely. And you can really, start looking at now you can really understand what are all the things you do, what impacts do they make? Some impacts are desirable, some are not, but until you start tracking it, looking at it, you won't know. And so I think data is going to be the big play.
Well, Scott and Lucas, it's late here. We've taken an hour of your time. I want to go home and say hi to my kids before we go to bed. So I'm going to cut us off here and say thank you very much for doing this on such a short notice. And Lucas, let's make sure we air this before the end of the year. We'll talk to our production and maybe shift the queue and try to get it before, or at least on that first or second week of January, because it'll be interesting. I'd love us to have this same conversation. Here's my invite to you, Scott. It's in 6 months. Let's touch bases again and see just what happened, because this is a story unfolding on a daily basis. And I think there's going to be a lot of moving parts to this, and it'll be very interesting to see where all of this ends.
No,
Okay.
you got it. I enjoyed it. Hope it's helpful, but I absolutely enjoyed it. And so now I appreciate it. And now it's time for you to go home, have dinner.
We
Yeah.
loved it. Thank you very much for your time. Be well.
Sure.
Anytime. Thank you.
Vamos.